Welcome to this explainer on acute bronchitis. If you spent even a day in a primary care clinic, an urgent care center, or just lived through a heavy cold season, you know exactly how incredibly common this presentation is. Today we're going to dive straight into the evidence-based reality of this condition, and more importantly, we're going to bust some major clinical myths along the way. My goal is to make sure you walk away with a perfectly clear, structured understanding of exactly what you're looking at and exactly what to do about it.
We've got a lot of ground to cover today. We'll hit the definition and etiology, walk through the clinical features and presentation, talk about diagnostics and investigations, and finally, wrap up with the treatment and management plan.
All right, let's jump right into part one, definition and etiology.
So what exactly are we dealing with? By definition, acute bronchitis is inflammation that's completely isolated to the trachea and the major bronchi. But hey, the absolutely crucial phrase you need to drill into your head here is self-limited. That means, this inflammation naturally resolves on its own. We don't need to jump in with aggressive curative medical interventions because it's just a localized physiological response.
Now, check out what's driving this. It is overwhelmingly viral. We're talking greater than 90% of acute bronchitis cases being caused by a virus. This is, hands down, the single most important statistic to keep in the back of your mind today. Why? Because recognizing this viral reality literally sets the stage for our entire management plan later on. Bacterial and non-infectious causes, honestly, they're incredibly rare by comparison.
Let's actually name some names here. On the viral side, which, again, dominates the landscape, we're looking at the usual suspects: rhinovirus, influenza, parainfluenza, coronaviruses, adenovirus, and of course RSV, which is definitely something to watch for in kids. But even though viruses run the show, you still got to remember the rare bacterial exceptions. Things like Bordetella pertussis, Mycoplasma pneumonia, and Chlamydia pneumonia. Oh, and don't forget non-infectious triggers. Environmental irritants and smoke can actually cause the exact same tracheal and bronchial inflammation.
Moving right along to Section 2, Clinical Features and Presentation.
Okay, this is a massive, high-yield clinical point, the actual journey of the cough. It usually kicks off on day 1 as a dry cough. But then, as we roll into weeks 1 through 3, that cough morphs into a productive mucoid cough. And here's the real kicker you need to take away. The median duration is a staggering 18 days. Yeah, almost 3 weeks. Understanding this 18-day timeline is absolutely vital for managing your patient's expectations because, let's be real, most people expect a cough to just magically disappear in a couple of days. So clinically speaking, your main job is differentiating acute bronchitis from something way more serious, pneumonia. With acute bronchitis, you're generally going to see no fever or maybe just a low grade 1. The patient might complain of some chest discomfort from all that coughing, maybe a mild wheeze, but systemic symptoms are pretty minimal. Now compare that directly to pneumonia. There you're hunting for serious red flags: tachypnea, focal crackles when you listen to the lungs, dullness on percussion, and severe dyspnea. If those severe signs aren't there, you're likely just looking at bronchitis.
Let's shift gears to Section 3, diagnostics and investigations.
Since acute bronchitis is fundamentally a clinical diagnosis, meaning, you're diagnosing it based on the history and physical exam without needing fancy tools like spirometry, we really have to ask ourselves a very practical question. When should we actually go ahead and order a chest x-ray?
Well, the short answer is that a chest x-ray is absolutely not routinely indicated. You should really only order one if you're suspecting pneumonia based on specific clinical red flags. What are those? A fever over 38 degrees Celsius, tachycardia, focal signs on your exam like crackles or dullness, or if you're treating a particularly vulnerable elderly patient or someone with significant comorbidities. If those aren't present, save the patient the radiation and skip the imaging.
And just a quick, high-yield pearl for your investigations. If your patient walks in with a severe paroxysmal cough, those violent, totally uncontrollable coughing fits, whether they have that classic inspiratory whoop sound or not, you need to broaden your suspicion. In that specific scenario, you really should consider a pertussis PCR to rule out whooping cough.
All right, bringing it home with Section 4, Treatment and Management Plan.
Because acute bronchitis is, as we established, a self-limited and overwhelmingly viral condition, treatment is purely symptomatic. It's all about making the patient comfortable. If they've got a severe cough that's ruining their sleep, you can offer antitussives like dextromethorphan. If you're picking up a noticeable wheeze, bronchodilators like a salbutamol inhaler are totally appropriate. And honestly, this is kind of neat. For a nocturnal cough, good old-fashioned honey is a safe and incredibly effective intervention as long as the patient is over a year old, of course.
Now, listen up, because here is the most critical warning for your daily practice.
Antibiotics are absolutely not indicated for acute bronchitis. I'll say it again, no antibiotics. And yes, this remains 100% true even if the patient's sputum is purulent.
I really want to reinforce this concept because it is so incredibly counterintuitive for a lot of patients and frankly, even some practitioners. Remember this golden clinical rule. Purulent sputum does not imply a bacterial infection. The gross discoloration and thickness of the phlegm, that's just a result of the inflammatory process and immune cells doing their job, usually fighting off a virus. It is not an automatic green light to hand out an antibiotic prescription.
So when do we actually reach for the prescription pad? Well, you should strictly reserve your antibiotics for some very specific exceptions, namely if you have confirmed or highly suspected pertussis or if the clinical picture strongly points to an underlying bacterial pneumonia. For your run-of-the-mill acute bronchitis, keep those antibiotics locked away.
Also, do not miss the golden opportunity to counsel your patient while they are highly motivated by, being miserable and unable to breathe comfortably. The evidence is crystal clear here. Smoking cessation is an essential, absolutely non-negotiable pillar of managing this condition and preventing future airway inflammation.
Which brings us to a final thought for this explainer. Knowing that this cough naturally lingers for a median of 18 days, and knowing that over 90% of cases are purely viral, we have to ask ourselves a pretty tough question in clinical practice. When you reach for a treatment, are you actually treating the pathogen based on the evidence, or are you just treating the patient's expectation for a quick fix in a prescription? Thank you so much for joining me on this explainer. Keep this evidence in mind the next time you hear that classic cough, and I'll catch you in the next one.